Good afternoon, everybody. I think we're going to get started. We're really excited to present this this afternoon. This is something very different from, at the end, I'd love to know if you could tell me how many of you knew about this breakthrough in understanding pain mechanisms and assessing how we can treat pain differently. Some of you may know this approach, what we're going to be presenting today, and many of you may not. So really the title of our symposium is Break the Mold in Pain Biology. And really the question is, can we harness a new mechanism to overcome the shortfalls in the management of severe acute pain? So I'm Charles Argoff. I'm a professor of neurology, and I run our pain center and pain fellowship at Albany Medical College in Albany, New York. And today, what we're going to do is divide the presentation into three. First, we're going to consider, I'll be giving that presentation, the current treatment for moderate to severe pain that we have available to us. Then Professor Ciccocioppo, Professor Roberto Ciccocioppo, who has flown from Italy to be here today, will speak about the promise of a new mechanism, the dual-NMR receptor, or NMR agonism. And then Dr. Jeffrey Gudin, Professor Gudin, who's on faculty at the University of Miami, will be talking about looking to the future and how we can utilize the information that we're learning today to break the mold in pain treatment. So let me just go over, and of course we'd love your questions at the end. So please think about those because we'd like to answer whatever we can. So what are we doing now? So let's talk about that. This is basic, I know. We're going to run through all this. We know that what pain is. We've been here, we're at Pain Week, which has been, many of you have been coming for many years, and we know that pain is not just a physical experience, it's also an emotional experience. We know that recently IASP came out with a newer taxonomy about pain, which now divides into three buckets. This is not perfect. A person may go back and forth with different conditions that are either nociceptive, which is pain that arises from actual or threatened damage to non-neural tissue and is due basically to the activation of nociceptors. We know about neuropathic pain, which is pain caused by a lesion or disease of the somatosensory system, so it would be peripheral, central, or both. And then the other bucket, which, interestingly, some really common pain conditions fall into this, like fibromyalgia, for example, is pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors or evidence for disease of a lesion of the somatosensory system. So it's not neuropathic and it's not nociceptive. And another big category of chronic pain, anyone want to think about that? Like what other really common chronic pain condition occurs that may have some features of neuropathic, but is really not classified as a neuropathic issue, but it's probably more common. It's the second leading cause of years lived with disability in the country, migraine. Right? It's not clearly nociceptive or neuropathic. And so you've got really big areas of chronic pain and pain in general. And then we have acute pain as well, which we know is often undertreated. So we also know that people are not always happy when they're being treated for acute pain. And we will define acute pain for the purpose of today's symposium and in general as characterized by having an inciting event or stimulus occurring suddenly with a limited duration of less than or equal to 90 days. So in the surgical setting, and I know Dr. Ciccocioppo and others who do work in the acute pain setting, besides yourself, of course, Dr. Gudin, around 75% of people experience acute postoperative pain, often moderate to severe, and greater than 50% of patients report inadequate postoperative pain relief due to limitations in either safety or efficacy of current treatment options. So, can you think of another condition that we take care of? I know it's not acute pain, but I just mentioned it earlier, where people, until a breakthrough was made, were not happy with their care. Migraine. 80% of people who were treated with a prophylactic agent for migraine over a 12-month period of time would not use that medicine anymore because it was ineffective or not well tolerated. So fortunately, the migraine biology is exploded, and hopefully we can break the mold in managing acute pain with a different way of approaching it. Because when non-opioids are insufficient, and any of you who manage acute pain, other instances in which you've used a non-opioid and it's not been sufficient for your patient with acute post-surgical pain? Non-opioids are always sufficient? Raise your hand if non-opioids are always sufficient. All right, so maybe I'm making my point. There are people for whom, when you're treating them in the post-surgical setting, non-opioid medications, which are preferred perhaps in some settings, are not sufficient. So I hope we would agree that short-term treatment with prescription opioids can serve as an effective management approach for acute pain, and that can include postoperative pain, burn pain, acute musculoskeletal pain, and dental procedures. Now, prescription opioids continue to play a major role in the management of acute and chronic pain, and there are risks, but we're doing this because they are beneficial to that subset of people and that group of people, but we're doing this knowing that there aren't alternative options right now. And what are some of the risks? It's only a glimpse. They include euphoria, potential diversion, physical dependence, psychological dependence, and respiratory depression. And you know that opioids have the benefit of providing pain relief, but they also are ubiquitous. I mean, I just sloughed off my keratinocytes, but beta-endorphin is expressed in your keratinocytes. That was work that we actually did at Albany Medical College. So you have opioid receptors everywhere, and that's where some of the concern about side effects may come from. So really, when we treat people with opioids these days, the benefit, weighing the benefits and the risks, the benefits are pain relief, improved mood and functioning, reduced care to family and caregiver. The risks include physical dependence, additional administrative burdens that we have, and in general, abuse potential, respiratory depression, and other consequences can be reduced function, as well as burdens on the family and care provider as a consequence of that. So this is an illustrative case just of somebody with acute pain. 69-year-old male who comes in following a fall. MRI shows a full thickness tear of the rotator cuff of his right shoulder. You can see the patient's history there. And this person, despite being managed with conservative, non-surgical therapy, PT, for example, NSAIDs, corticosteroid injection, people who you might see in your practice or have referred to you, remains in severe pain. So let's hold that thought, hold that patient, and then think of why do we need better treatments? We need better treatments for the management of acute pain because we need a treatment that allows for strong analgesia, but a lower abuse potential and limited physical dependence when it's instituted, and reduced respiratory depression, obviously for safety. So can a new class of pharmacotherapy improve upon our current treatment challenges and available agents? So I'm going to leave you with that thought and invite Professor Ciccocioppo to come up on the stage and tell us about the promise of a new mechanism. And thank you for your attention.
Thank you for being here, so numerous. I guess the food reward plays its role here, but I'm sure they'll be also interested to know a bit more about this molecular pharmacological mechanisms that is serving a new class of molecules that is under development to treat pain. I'm a professor of pharmacology and director of the Neuroscience Center at the University of Camerino in Italy. And I started working on the nociceptin system and the nociceptin NOP receptor relationship more than 25 years ago when I was a PhD student. So when I started to write my PhD thesis, probably I published the first few papers on nociceptin and on its effect in the regulation of reward mechanisms. And so for me now it's exciting to be here and talk about the clinical use of these mechanisms, because now we have drugs under advanced clinical development for acute pain. Before entering into the description of the mechanisms, think of the opioids. The human being, us, have learned the use of poppy extracts, poppy seeds, to treat pain more than 3,000 years BC, which means 5,000 years ago. So 5,000 years ago, we already knew that opioidergic compounds have important analgesic effects. In 5,000 years, we are still using opioids. And this is one of the primary treatment to obtain a good analgesic effect. And I think this is telling something. This is telling at least something to me. This is a major molecular target. You know, the opioid system is a major molecular target to treat pain. But we also learned, you all know better than I do, that activating the µopioid receptors and to obtain analgesic effect through the activation of these receptors is also associated with important side effects, which are the respiratory depression, the risk of abuse potential, dependence, etc. Still remains a major treatment for pain. Over the last 20, 30 years, major pharmaceutical efforts have been made to obtain better opioid-based treatments. But those efforts have been largely focused on developing strategies to change the pharmacokinetics of already known molecules, to reduce the diversion of these molecules so that they are less abusable. While here, I'll be talking about a complete new mechanisms that consist of the co-activation of classical opioid receptors, mu, delta, and kappa, particularly mu, with another receptor that is the NOP receptor, the nociceptin receptor. And I think that this complete paradigm shift in the treatment of pain. You all know about the mu, delta, and kappa receptor, endorphin, enkephalin, dynorphins, the endogenous ligands. So I'm not going to spend time on this, while I spend a little bit of time discussing the pharmacological properties of the NOP receptor and its endogenous ligand, that is nociceptin. We all know the opioid receptors and systems because they have been characterized around the mid-70s, and their description is in all textbooks, on the pharmacological and medical textbook. But 20 years later, around the mid-90s, another receptor was discovered that was originally named opioid-like receptor 1, or RL1. And the reason for this name is that once the receptor was cloned, it was found that had some structural similarities with the kappa receptor. But the classical opioid peptides, dynorphin, endorphin, and enkephalin, did not bind to this receptor. Still, it was named opioid-like receptor. 2 years later, in 95, 96, the endogenous ligand, this new peptide, was isolated in the brain and characterized and was named nociceptin or orphanin FQ. So now we have this fourth receptor, and we renamed it NOP, and the peptide, the endogenous ligand, that is nociceptin orphanin FQ. And this also led to the renaming of the classical mu, delta, and kappa. And in fact, the mu, delta, and kappa are now also known as MOP, NOP, DOP. And this was because of the discovery of this new molecule of nociceptin. So the first time I injected nociceptin in the brain of a rat, it was in 97. The first thing I noticed in an animal model, it was a rat model of excessive alcohol drinking, that nociceptin injected into the brain of these animals were reducing their motivation for alcohol. This was the first published paper showing that activation of this receptor reduces the consumptions of substances of abuse. Many other papers have been published by other research groups and myself. There are now more than 200 papers published describing the role of nociceptin and nociceptor in the regulation of drug of abuse consumptions, motivation, reward, etc. And ultimately, they all end up saying that activation of this receptor reduces the consumptions of psychostimulants, amphetamine, cocaine, alcohol, nicotine, morphine, heroin. And stemming from, and actually other observation over years demonstrated that despite this receptor reduces the motivation for opioids and therefore possesses anti-opioid properties, it potentiates the analgesic effects of opioids, of morphine, and also attenuates the respiratory depression caused by opioids. And I'll take you through this data so you can better understand what actually the activation of the receptor does at physiopharmacological level. But before showing the data, I want just to point out your attention to this. This is the distribution of the nociceptor in the mouse brain or in the dog brain. You see a lot of receptors, a high receptor density in all cortical regions, in the thalamus, in the limbic regions, in the amygdala, in the hippocampus. And the same distribution is in a human. This is a PET study with a selective NOP ligand in a human volunteer, an healthy volunteer. And you see a huge distribution of the receptor at level of the cortical structures and also in the thalamus. Why I'm showing this data, these pictures? Because this is telling us that the system is phylogenetically highly conserved. And this is what we should expect from an opioidergic system. Opioids are ancestral systems that we can find in nature, from very primitive animals to humans. And in fact, if you think of the analgesia, opioids, agonists, mu-agonists, are analgesic in rodents, but also in monkeys, in humans, right? So the concept is that what we see in animals, what we see in laboratory animals, then can be translated into humans. The effects that we observe in laboratory animals, we should expect to see also in humans. And actually, now that we have compounds that activate the NOP receptor, actually co-activate the NOP and MOP receptor, we start to see this in clinical studies. So let me point your attention to this, to the effect of nociceptin agonist on pain. This is an analgesic model in primates, in monkeys, in which the effect of morphine was compared to that of UFP-112, that is an experimental molecule that binds to NOP receptor and activates this receptor selectively. As you see, compared to vehicle, morphine produces an analgesic effect, right? Increases the tail withdrawal latency. But UFP, that is the NOP agonist, produces a similar effect, is as potent as morphine. Even more important is when the two molecules, morphine and UFP, have been combined. When they're combined, and you see the dark histograms, they even show synergistic effects. So the combination, the co-activation of mu-opioid receptor, or classical opioid receptor, and NOP receptor produces an even better analgesic effect. Not only that, in the same study, authors demonstrated some other interesting features. They looked at the side effects of the morphine compared to the NOP agonist, to UFP. In monkeys, one of the side effects associated with the activation of mu receptor is scratches. So you can see on the left-hand side, my left-hand side, the analgesic effects of, oh no, okay. That's the one I was supposed to show you. Here you see the effects of morphine as compared to UFP in terms of scratches and analgesia. You can see that morphine can lead to analgesic effects, but at the same time produces substantial scratches in monkeys. The UFP produces a dose-related analgesic effect without eliciting scratches in monkeys. So it's analgesic without this side effect. And all this data over the years stimulated novel efforts in drug development programs to synthesize new molecules that are able to bind simultaneously mu opioid receptor, mu delta and kappa opioid receptor, and NOP receptor. And we now have these molecules. And one of these molecules that is fairly advanced is the GRT6005 that is at clinical stage. And if I put together what we have learned testing these molecules, testing other NOP agonists compared to mu agonists, this is the summary panel that I can pull out. If we compare the pharmacological characteristic of morphine to that of GRT6005, what we do see? We do see that morphine is highly efficacious in treating nociceptin pain, right? We all know this. It's less efficacious in treating neuropathic pain. Higher doses are needed, and in general, less efficacious. And also, we know that the side effects of morphine overlaps substantially with the analgesic effects of morphine. But the same is for oxycodone and other classical opioid agonists. We don't have a dissociation between the therapeutic effects and the side effects. Using GRT, actually, what we have learned is that it is efficacious in neuropathic pain, and this probably reflects the properties of NOP agonism, because selective NOP agonists have effects on visceral and neuropathic pain. They are also efficacious in nociceptive pain, as we would expect, while the side effects that we would expect by activating MOP receptors, mu receptors, occurs at higher end doses, at doses that are higher to those that we need to produce analgesic effects. How about the motivation for this drug? This is a compound, 6005, that is a highly potent mu agonist that combines these properties with its ability to activate NOP receptor. We would expect from a NOP agonist to be abusable, right? So we conducted a number of studies. These studies were done in my laboratory, in which we asked the animals to self-administer heroin. We trained the animal to heroin self-administration. Rats, rodents, like heroin, as we do. So we can train animals to self-infuse heroin. They are catheterized. They can press a lever. Pressing a lever, they self-infuse 1 dose of heroin. Over the days, they learn that heroin is good. They like heroin. They start taking heroin until they reach a baseline. Once they reach a baseline, they maintain their self-administration we can ask the animal, okay, now I want to know how much you like heroin. So I shift the animal to what is called a progressive ratio schedule of reinforcement. Progressive ratio that you can see here, oops, sorry, let me go back. The progressive ratio is here. It's a schedule according to which the animal pressed for the first dose of heroin 2 times. For the second dose, 4 times. For the third dose, has to press 8 times. And the fourth dose has to press 16 times, and so forth. So we can measure the effort the animal is willing to emit to obtain 1 dose of heroin. And as you can see here, the higher is the dose of heroin, the more the animal is willing to work for it. So when we give 60 micrograms per infusion, the dark histogram, you see that the animal is willing to press up to 60 times that lever to obtain 1 dose of heroin. 60 times is a lot. It means that he's pressing that lever for a few minutes to get to the point to obtain the reward. But if we played the same game, but instead of giving heroin, we give GRT 6005, that is a mu agonist, but also an op agonist. As you can see here, the animals are not pressing them much. The break point is not distinguishable from zero, from saline, from the vehicle. And this is telling us that the co-activation of these 2 receptors is reducing dramatically the liking for this drug, at least in rodents. And this is very important. And it's even more important if we think of the potency of this molecule. As you can see here from the graphs, the animal were infusing 60 micrograms, up to 60 micrograms of heroin, while in the case of GRT, we had to go down to 6 micrograms, much lower. And this is because the affinity of this molecule for mu receptor is very high and is very potent. Imagine that it's as potent as fentanyl in terms of its ability to activate mu receptors. Still, seems to have low liking properties, and therefore is very different from fentanyl. The same has been also found in monkeys. Very similar studies in which GRT was compared to fentanyl, in this case in monkeys, in another laboratory, not mine. And what they found in the progressive ratio schedule of reinforcement here is that the animals are more prone to have a high break point for fentanyl. They have higher break point for fentanyl as compared to GRT. Still, GRT is as potent as fentanyl in terms of analgesia. So this is telling us that is definitely equianalgesic to fentanyl at least, but with much less abuse liability. Studies have also been done to evaluate the possibility, the ability of GRT to lead to physical dependence, because this is another important feature of opioid agonists. So in this study, I'm not showing the data for the sake of time. I'll show just this cartoon. But animals were treated for 4 weeks with very high doses of GRT compared to morphine, 300 micrograms. Imagine that the maximum analgesic effect is around 10 micrograms. So imagine how high was this dose. For 4 weeks, and at the end of the treatment, the animals were withdrawn from the treatment, and the expression of spontaneous withdrawal was measured, was evaluated. And also the expression of naloxone-induced withdrawal was later evaluated after another period of re-exposure to the drug. And if you read through the lines there, what looks like is that the physical dependence elicited by GRT it's lower compared to morphine, for example. So at the end of the treatment, when the treatment is stopped, we would even following chronic treatment, we would expect in humans reduced expression of withdrawal. That is an important feature. Now, another characteristics of opioid agonists is that they produce respiratory depression. And actually, this is the major side effects following acute intoxication with opioids. And so we also, well, not myself, but other laboratories looked at whether coactivation of NOP and MOP, for example, using GRT, would affect the respiratory depression, would have different respiratory depression profile. And in this cartoon here, you have the comparison between fentanyl and GRT in terms of analgesic properties and respiratory depression properties. So what you see here, for example, is that with fentanyl here, we have an important analgesic effect, as we would expect in the tail flick test, this classical test used in rodents. But the tail analgesic effects, the analgesic effect occurs at doses that also produce significant respiratory depression. In the case of GRT that coactivates MOP and NOP receptors, the situation is different. Here, we have a significant analgesic effect, but the respiratory depression is barely visible. And also I want to point out the equipotency of intravenous GRT as compared to fentanyl in terms of analgesia. So we are dealing with a compound that is as potent as fentanyl, but has much less respiratory depression properties, these animal models. Same has been found in monkeys. This is another study carried out by colleagues in US, by Old and Co. And what it found is that if we compare fentanyl to GRT, with fentanyl at analgesic doses, 56 microgram per kg, we have substantial reduction in the breath per minute, while in the case of GRT, we don't see such an effect. How is this happening? Is it possible that depends on the activation of NOP receptor? I think we have data that are demonstrating this. This is a study published a few years ago by Linz and co-workers. What they did looks like a bit complicated, but is not, and I'll take you through. What they did was to study the effect of J11. J11 is a selective NOP antagonist in addition to GRT that coactivate NOP and MOP. So the concept is this. I'm giving GRT that activates the two classes of receptors, but I'm going to block the NOP component. So I will disinhibit, I will unmask the mu component, and let's see what happens to the PO2, the partial oxygen pressure, O2 pressure, and CO2 in the blood. And what you see here is that GRT alone here produces a modest respiratory depression. But if we block the NOP component by co-administering J11, here is that the respiratory depression increases. So this is telling that actually is the activation of this NOP receptor that is protecting from these side effects of mu agonism. And in fact, if we give the mu antagonist naloxone, we can rescue in animals that were treated with GRT plus J11 the respiratory depression. So yes, the respiratory depression caused by GRT is mediated by mu. But if at the same time we coactivate NOP, we protect from this respiratory depression. And I think that it's one of the most exciting aspects of these mechanisms that involve the coactivation of the two classes of receptors. So I think my time is over. I could talk about this for another hour or so, but your lunch is finished, is ended. It's time for a coffee. So I don't want to take more time. I would leave the stage to Jeff that is going to close this conversation with you. And I would leave you just with these three main messages that are coactivation of the two receptor system, MOP and NOP, represent a new molecular mechanisms leading to an expansion of the analgesic properties of this class of molecules, while at the same time reducing some of the major side effects associated with activation of mu receptors, which are respiratory depression and abuse liability. And therefore, I strongly believe that this class of molecules are highly promising, and I hope to meet you again in a year or two talking about the clinical use of this new class of molecules. Thank you so much.
Anybody else think that's really cool? Really cool, right? So Roberto, well-deserved round of applause. Imagine being able to explain that so clearly in a language that's not your own, right? With a really cool accent, by the way. But so no, the data is relatively remarkable. And for those of you that attended the Analgesics of the Future lecture yesterday, this is how new molecules are developed. They start out in preclinical testing models, have to go through all the mouse and rat studies, and we hope the data translates to humans. This particular chemical is pretty far along in phase 3 trials for acute pain. So we'll have some data for you hopefully soon about the translatability of what you've heard today. But for those of you that heard any of my talks so far at Pain Week, by the way, if you haven't met me, I'm Jeff Gudin. I'm a pain doctor originally from the New York, New Jersey area, now down at University of Miami. Pain and addiction medicine, palliative care background as well. This is what you've heard, really exciting, because as I've mentioned in previous talks, we're really trying to find an analgesic that works, and it works enough that we don't have to prescribe 10 other things alongside of it, but that takes away the dangers of the class of analgesia that we think of now as really the only class that treats severe levels of pain, and that's opioids. So I'm not going to beat that too much, but let's go back to the case that Charles presented a little bit earlier. And this is a kind of like, what do? We all have these patients. He's got really, real pathology. He's got real comorbidities. He's been trying his hardest to avoid more injections. He certainly doesn't want to have surgery. He's in severe pain. He's doing his PT. He's trying his, ancillary stuff, his over-the-counter analgesics. You've given him, if you're like the primary care docs in my town, tons of gabapentinoids already, which really don't do very much for musculoskeletal pain. And he's saying, look, I need to do something. I can't work. I can't function. So what do you do for a patient like this? These are the patients who we put on our hats and we say, hey, is there some balance that we could find to let this patient have a stronger class of opioid for a short amount of time while he gets through his acute pain stuff? So the patient and his doc opt for surgery, which obviously intensifies his postoperative pain. He didn't get any better. put on some kind of medications, and it's our job to figure out, can we balance what we do to the patient, what we prescribe the patient, to improve their quality of life and function, while trying to minimize the side effects of medicines like opioids, which we've been talking about already for a few days. So let's just talk about what some of the treatment options are. I'm sure you're all familiar with the dangers of NSAIDs, and I almost didn't put this slide in there. GI, cardiovascular, renal especially. I work in a hospital-based setting. We see acute renal injury from NSAIDs all the time. This happens with short-term NSAID use. Antiplatelet effects, bleeding consequences as well. But I put this up here because I remember when the COX-2s first emerged, there was a lot of data about what are the dangers of short-term ibuprofen or short-term naproxen. And the data I think the author was saying that sticks with me the longest time is they took patients and put them on naproxen for 7 days. And on the 7th day, they put the little mini cameras, a little endoscope up the nose and down into the stomach. And something like 50% of them had gastric ulcers, 7 days on naproxen. I have patients that ask for their 800 TID of ibuprofen month after month after month after month. And the trouble with these ulcers that they find endoscopically is they're usually asymptomatic. But they're usually asymptomatic until they're not asymptomatic. And those are the GI bleeds and the low hemoglobins that you never know of, and the tachycardics from being anemic that you don't realize, that lead to cardiovascular outcomes because they're having these GI ulcers. So I like NSAIDs, but it's one of the few classes of drugs that I make patients take a holiday. I don't let my patients take NSAIDs every day. Some of them do anyway. And you know that one of the dangers or one of the issues we have with NSAIDs is we try to prescribe more of the COX-2 selective, meloxicam, celecoxib on that end of the spectrum. Patients go home and take Advil for rescue or Aleve for rescue. They don't know the difference, so you need to educate your patients. But NSAIDs, to me, are not a good long-term treatment option. Here's another pretty interesting factoid. Some of this comes from Medicare and chart review data. But what do you think the chances or the probabilities are of being on an opioid long-term if you're given a short-term prescription? So here's the data here. Long-term use defined as 1 year was 13% if you got 8 days worth of opioids, and 30% of patients that took an opioid for 30 days were still on it 1 year. A third of patients that took opioids that got opioids for 30 days were still taking them at 1 year. 1 in 7 people that got a second prescription or a refill were still on opioids a year later, a separate data set. So we need a class of drug. I'm not saying those patients didn't have pain, but we need a class of drug that we could do for a year that has an improved side effect profile. So you heard about this new mechanism of action. This may be the first time you've heard of it. It's been in development for quite some time. This dual-NMR, right? Nociceptin, µopioid receptor synergy that we all know what mu does. But you heard from Dr. Ciccocioppo that when you add in the ORL, or the nociceptin peptide, where you activate the nociceptin receptor, you get better analgesia, you synergize the analgesia. This is from his data. Here's morphine alone, here's NOP alone, UFP, and here's the combination of both. This is analgesic data from animals. You synergize the analgesia with the added benefit of limited abuse potential. I had a chuckle when he said how many times the rats press the lever to get the heroin. That's really cool, right? My kids have this M&M dispenser, and the lever on it sticks all the time, right? And I literally sit and I try to press the lever. I mean, I could be a rat in the lab. Like how many times I have to press the lever to get my M&M. And if it's the pretzel M&Ms, I'll press a couple hundred times to get the M&M out. But it's really cool how we measure likability in animals, and they're like, how much work are they willing to go through to get another dose? And you saw when we synergize mu with NOP, the abuse potential was limited. They completely and abruptly stopped the medication without signs of abstinence syndrome, without signs of withdrawal. These are some of the characteristics of analgesics that we're looking for our patients. Better analgesia, less side effects. And I mentioned in a few of my talks before, the most dangerous thing, respiratory depression. And you saw here clearly it mitigated the respiratory depressant effects of opioids. So where might this drug play a role in our world? Well, think about it. Almost any place. You heard there was some evidence for neuropathic pain. Clearly a place like inflammatory pain or OA, any acute pain, burn pain. Agonizing the MOP and NOP receptors leads to some synergy between the two and gives you better analgesia than either one alone. And here we can get it in one molecule that you've heard about. I already mentioned there are some clinical trials underway for this, and hopefully, like Dr. Ciccocioppo said, in years coming, you'll hear more about this and even read more about it in our pain literature. Dr. Argoff showed a slide that we really need to fix our risk-benefit analysis. I won't belabor the point and take you through it, but we think with a drug like this, we can really level the playing field, take away the abuse potential, take away that physical dependence, take away the ceiling effect on respiratory depression. One of the molecules, the one that's in trials, had a poster here last year, at this pain week last year, that looked at drug likability. Asked recreational abusers how much they liked the drug compared to drugs like tramadol and oxycodone, and there was significantly less likability, just above placebo. When you look at likability of oxycodone, it was way high. So I'm excited to see further development in this particular area. I think we're pretty convinced at this point that it's a well-validated concept, this dual NOP-MOP receptor agonism, the mechanism of action. It's clearly a promising therapeutic drug that's in development. And again, anytime we could develop an analgesic that works, that has less abuse potential, less physical dependence, and a lower ceiling for respiratory depression, I think we would all welcome that into our practices. So if you'd like more information about the development or the chemistry behind this drug, Tris Pharma has a booth here in the exhibit hall, booth 220. You can take a picture of the QR code, stop by the exhibit center. I think we have a little time before our next session, maybe 8 or 10 minutes or so. If there are any questions, I'd like to invite my colleagues back up to the podium. And please, I'm sure most of the questions will be for our visiting professor, but we're happy to answer any you might have. How about a round of applause for our speakers?
Could you make the animal go apneic, or did you hit a wall with the respiratory depression?
I barely heard you.
I'll take it.
Yeah, so I think when you're using a NOP antagonist, if you went up on the parent drug on GRT and you used the NOP antagonist at the same time, if you went to too high a dose, did you create respiratory depression?
So could you cause the animal to go apneic when you went up on the GPT while using the J11 antagonist?
Because you're blocking a NOP effect, does the mu receptor opioid effect come out and cause apnea?
At least what we have seen in laboratory animal is this, that if we block the NOP component with an antagonist, then we unmask the classical opioid effects in terms of respiratory depression, probably also abuse liability.
So the GPT does not have a ceiling on respiratory depression like buprenorphine when you give the NOP
No, it's completely
antagonist.
different because the ceiling effect of buprenorphine is linked to the fact that it's a partial agonist. So it activates the receptor up to a certain point, but does not have 100% efficacy. While here, we are basically working with a completely different mechanism. So it's a pharmacological interaction between the two receptors. So we are dealing with a system that is actually different from buprenorphine. And actually, also in terms of analgesia, I would expect a complete different profile in a sense that one of the limits of buprenorphine is that also for being a partial agonist, also for analgesia, we have a ceiling effect. While with a full agonist, like GRT, that in addition to this binds also to NOP, we would expect a higher level of analgesia.
Other questions? Hard to see hands if there are any. And feel free to come up to the podium. Any other hands? Thank you, guys. Enjoy the rest of Pain Week.